Good evening, everyone. Can we start the section, sir?
Yeah, I think we can start the sessions.
Yes, sir. Yes. Thank you, sir.
Yeah.
Good evening and a very warm welcome to all our esteemed faculty members, clinicians, researchers, and delegates joining us today. I'm Rukmini from Team IAIO, and it is my privilege to welcome you all to IAIO Expert Insights session on gastrointestinal cancer. This academic initiative brings together experts from oncology and pathology to share evidence-based insights focused on HER2 testing, interpretation, and its clinical relevance in gastric malignancies. We would like to sincerely thank our sponsors for their valuable support and continued commitment towards advancing cancer care and precision medicine. We are confident that today's session will provide meaningful learning and practical takeaways for all participants. To set the stage for today's discussion, I am pleased to invite Dr. Imanshu Ajay Tillu, Diagnostic Manager at AstraZeneca, Mumbai, Maharashtra, to provide a brief context and overview of the section. Sir, the floor is yours.
Well, good evening, everyone. Thank you so much, Rukmini, for the introduction. And thank you, IIO, the organizers, for this opportunity. A big hello to all the faculty members and for this session, and also to the audience who have gathered here to listen to what the experts have got to say in the field of HER2 in gastric oncology. So I will keep it very brief, and I will just share with you a few of my thoughts, which will be later taken up and discussed in a very elaborate way by our eminent faculty here, and when they share their expertise with her. So quickly, I'll just share my screen. Rukmini, do let me know if it is visible whenever it is.
Yes, sir. Yes.
Yeah, can you see?
Yes, sir, it's visible.
Okay. Yes. So today we have all assembled here for what promises to be a series of very engaging sessions. We will start with Dr. Vidya, who will take us through the details of HER2 scoring and interpretation in gastric cancer. Followed by that would be a very engaging panel discussion, which I'm sure would be very insightful. And then Dr. Sudeep Das will take us through the role of HER2 in gastric and gastroesophageal junction carcinoma landscape. So we all know how serious of a problem gastric cancer is. It's according to Globocan data, it's the 6th most common cancer type with an incidence of more than 60,000 cases. And it's also the 6th most common cause of cancer-related deaths. If we speak of India, around 50% of the cases are diagnosed in the loco-regional stage. But however, around 25% cases are also diagnosed as distant metastasis. And as we know, basically as what is expected, as the stages advance, the chance of survival drastically reduces. However, there is some good news, and the oncology community has made major strides in the area of gastric cancer management, and we have quite a few targeted therapies coming up, which are targeted against specific biomarkers, which you can see here. So let's take the example of trastuzumab deruxtecan. Now, before that trastuzumab deruxtecan was approved, that SOC, the standard of care at that time, if you look at the overall survival, it was less than 10 months. And what Destiny Gastric trials demonstrated is that TDXD was able to improve the overall survival to more than 12 months. While this looks like 2 to 3 months, but we all appreciate that 2 to 3 months can make a huge difference to a life of patients and their family members. And when we speak of TDXD, which is a HER2 targeted therapy, it is imperative, it goes hand in hand that we discuss about HER2 testing. And as we all know, HER2 testing and interpretation in gastric cancers is not straightforward. It's quite complicated. It's complicated by the fact that of the focal patchy positivity that is a landmark of gastric cancers due to the high degree of heterogeneity of HER2 that is observed. Also, HER2 expression is not uniform across multiple histological subtypes of gastric cancer. We know that it's more common with the intestinal subtype and JEJ subtypes, but it is with the diffuse subtypes, the HER2 positivity is very, very low. Now, if we look at the global data, generally accepted positivity rates range from around 10 to 20%. There are certain Indian studies who also report gastric positivity rates from 14 to even 56%. Now, this brings a question to the mind: what could be the reason for this variability? Uh, to further complicate the matter, when we go and speak with the labs, speak with the doctors, they say that the HER2 positivity in their settings is often very, very low, very, very low, than less than 10%. Now, what could be this begs an answer. What could be the reason? Is it that not enough biopsy fragments are captured? Is it something to do with the disease? Is it something to do with the assay itself? Is it something to do with the scoring system? So all these questions need to be discussed, and this is exactly what our esteemed faculty members are going to do. So without further ado, I will hand it over to Dr. Vidya, who will take the first session, and then the next panel discussion would be moderated by Dr. Subbalakshmi, and the panelists would be Dr. Rukmini, Dr. Arpita, Dr. Anand, Dr. Saurabh, Dr. Paulomi, and then finally Dr. Sudeep sir will take us through the role of HER2 in gastric and role of HER2 in JEJ landscape, basically. So with this, I stop here. Over to you, Rukmini.
Yes, sir, yes. Thank you, Dr. Imanshu, for the insightful opening. We now move to our first scientific talk of the evening. It is now my privilege to introduce our first expert speaker, Dr. Vidya Eman, a lead consultant in histopathology at Manipal Hospitals, Bangalore. Dr. Vidya is a highly respected pathologist with vast expertise in gastrointestinal pathology, oncopathology, and molecular diagnostics. Her precision in reporting and dedication to improving diagnostic standards in cancer care are truly commendable. She will be speaking on HER2 scoring and interpretation in gastric cancer. Please join me in warmly welcoming Dr. Vidya Eman. Ma'am, over to you, please.
Thank you, Rukmini, for the kind introduction.
Thank you,
So
ma'am.
let me begin by sharing the screen. You let me know once the screen is visible.
Yes, ma'am. Yes, sure. Yes, ma'am. It's visible.
Yeah. Good evening to one and all. So I would first of all want to thank IAIO and AstraZeneca for giving me this opportunity here. So without much ado, the task given to me before the panel discussion is to take you through the nuances of HER2 new scoring and interpretation in gastric cancer. So as we all know, now HER2 new and MMR have become tumor agnostic. So more so ever in gastric cancer, because we know how fatal it is for the patient, and especially so in advanced cancers where the medical oncologist will want to try more treatments or whatever possible treatment is required for the patient. So hence HER2 new testing has become very, very important, and it has become sort of a reflex test in our laboratories along with the panel that Dr. Himanshu showed you people earlier. So it is now that we always try to do the HER2 new, the MMR, the PDL1, and now recently we have started adding the Claudin as well. And there are a few more biomarkers which are coming into picture, especially for your GE junction and gastric cancers per se. So the slide is not okay. We know that there are multiple pathways which are generally involved for these tumors to proliferate and metastasize, and obviously few important markers or the pathways that are involved include our receptor tyrosine kinases, which include your EGFR, your HER2, etc., which cause lot of pathway activity and down cascading effect within the tumor cell. So once the tumor cell gets mutated on these pathways, so we can see that there is a lot of cell proliferation and tumor activity happening, which can lead to tumorigenesis as well as metastasis, and hence it leads to a lot of disease progression in the patient and eventually high mortality in these instances. So the main thing is HER2 has become the poster child for the targeted treatment. We know that it started way back in breast cancer. Now it has moved all the way to gastric cancer, then your other cancers like your biliary tract, your uterine, your cervical cancers, your colorectal cancers. So it is becoming more and more tumor agnostics. But you need to understand that the HER2/neu scoring may not be uniform across all these cancer systems, and breast has a scoring pattern which we are all familiar with, and gastric has its own scoring algorithm, and hence the pathologist has to clearly identify what is a scoring algorithm and what nuances are there in adoption of the HER2 testing for gastric and GE junction cancers in the laboratory. So as rightly pointed out, there are a lot of things involved in terms of seeing your slides, viewing your slides, preparing your slides, and also in assessing what exactly is positive and what are the drugs involved. And you need to have a two-way communication with your medical oncologist for the correct, guided, precise treatment for the patient. So, as told, breast cancer, HER2/neu in gastric cancer is driven by the amplification of the HER2 gene. So, when we look at HER2/neu, we look at two or three things which are very, very important. One is HER2 expression, which is assessed by IHC. The other is HER2 amplification, which is assessed by our FISH or the ISH tests, which act as reflex tests in most of our laboratories. And we see HER2 mutations for few other cancers, which is tested by our NGS or our PCR-based methods. So when we talk about expression, we are looking at IHC test in the laboratory. When we're looking at amplification, we're looking at ISH test, and all these are involved as part of the tumor progression in the patient. So when we look at this, there is going to be HER2 expression in these gastric cancers, which leads to tumor cell growth and proliferation, and which can cause a lot of metastasis and advanced cancer in the patient. So there were various studies which were conducted, and the studies were way back in 2013. So this is one of those studies which studied about more than 2,700 cases. They had the resection specimens as well as the small GI biopsies or endoscopic biopsies, and where they tried to assess what could be the correlation between the HER2 expression in these gastric cancers versus the prognosis and versus the advancement of the disease in the patient. So they realized that most often the HER2 positive expression cases behaved very badly, or the prognosis was poor in these patients and the disease progressed very rapidly. And hence HER2 expression in gastric cancers or GE junction cancers was considered as a poor prognostic factor. The other thing they realized during the study process was that advanced age patients more than 60 years had high levels of expression of this HER2/neu, and also the histopathology, as rightly pointed out, intestinal type showed a lot of HER2 expression. So here we have HER2 expression in the histological types, which the pathologist has to rightfully assess during the study of the slides in the laboratory, and also correlate with the other demographic data also of the patient. And the other thing that was realized was the HER2 expressions went on predominantly in the GE junction areas and also in the proximal stomach rather than the distal stomach cancers, where the rate of HER2 expression was very high. So when we look at the prevalence in the I'll just switch on my pointer. Yeah. So we have one spectrum, the GE junction, and the other spectrum, we have the gastric cancers, which could be either your body or distal gastric cancers. And we can see that HER2/neu was expressed in almost 12 to 20% of the gastric cancer cases, whereas it was much higher in the gastroesophageal junction tumors, which was around 33%. And in this, the split was that the intestinal type, almost 30% of these cancers showed HER2 overexpression, whereas the diffuse type was less, which was around 5%. I think this is what is generally observed even in our laboratories. When we see the poorly cohesive carcinomas or the signet ring cell adenocarcinomas, we see that the tendency towards HER2 expression is very, very low in these cases. Whereas intestinal type, the well-differentiated carcinomas or the grade 2 carcinomas definitely express HER2/neu. But still, as rightfully pointed out, there is low percentage of reporting in our labs. We can see that in my own lab, it is somewhere around 10 to 12%. I don't think we are anywhere close to 30% or 12 to 20%. So let's see in the next few slides what could be the reasons for this, maybe underreporting or maybe under finding of this HER2 expression of the gastric cancers. So now the guideline recommendation across all the frameworks is to test HER2/neu in all cases of advanced and metastatic gastric cancer. For example, you can see the NCCN guideline network, and then we can see that they clearly dictate that inoperable, locally advanced, recurrent, or metastatic adenocarcinoma of the stomach has to be tested for HER2/neu. If you look at ASCO-CAP, advanced GE junction and who are considered good candidates for combination chemotherapy plus trastuzumab therapy. So we know that now trastuzumab is there, and now not only trastuzumab, it is also your Enhertu, which has come into picture for your solid organs, which includes your GE junction and your gastric cancers as well. If you look at ESMO clearly says metastatic gastric cancers have to be tested for HER2. The JSMO and ESMO also says that in metastatic disease setting, we have to test for HER2/neu in all gastric cancers. So now we know that it is compulsory that in your labs you need to do the HER2 testing along with your PDL1 and your MMR studies for gastric cancers. The gastric cancers, unlike the breast cancers, are notoriously heterogeneous because we have distinct subpopulations of this tumor. So what do we mean by this heterogeneity? One is intratumoral HER2 heterogeneity. That is, this tumor can exhibit patterns like, for example, you have 5 to 6 endoscopic bits. One bit will show HER2 expression, the other bit may not show. So this is intratumoral heterogeneity, where within the same tumor, some cells will express HER2, whereas some cells do not express HER2. Concurrent genomic alteration, this is another significant heterogeneity of these cancers, where not just a single pathway like your HER2 transmembrane receptor that is going to be affected, but there can also be other cross-link pathways like your PIK3, which can be overexpressed, and hence this may cause trastuzumab resistance. So you know that when you have these kind of pathways, and even though you may say that this patient has 2+ or 3+, which is ish proven as well, but may not be really responding well to treatment, that could be because of resistance due to activation of your other pathways. We have intra-patient HER2 heterogeneity. What do we mean by intra-patient HER2 heterogeneity? For example, you have in the same setting a primary tumor which has been sampled and also a metastatic tumor of the same patient which has been sampled, a lymph node metastasis. Lymph node may show positivity and the primary may show negativity, and vice versa. So you definitely have an intra-patient HER2 heterogeneity which can happen in gastric cancers. And also, over a period of time, loss of HER2 expression. This is becoming tedious even for the medical oncologists, because during the anti-HER2 treatment that happens, initially I've reported that the gastric cancer is HER2 positive, but then when there is disease progression and you try to test the metastatic setting or the recurrent site setting, and you may see that the HER2 is negative. So this is how heterogeneous the tumor can be, and also acquired genomic alterations which can lead to a lot of resistance or mutagenesis to your ongoing anti-HER2 treatment. So you can see that is the reason why I termed this as it is notoriously heterogeneous, and hence you may have underreporting also being happening, because we know the endoscopic bits, especially at the time of primary tissue diagnosis, is going to be very scant and may not represent your whole tissue. For example, now you can see in this image itself, to the left-hand side, you can see that the gastric glands, the adenocarcinoma glands, have lost expression. It's like 0, or maybe towards one edge it is 1+. But the same glands are also showing 3+ in few other areas. So this may be an image from a resection specimen, but you can see that in the endoscopic specimen, we are looking at as less as 5 cells being positive in a cluster. So that is the reason we are saying that these tumors are heterogeneous, and you need to be really aware and test all the tumor tissue bits whenever you are going to test the HER2 samples in your lab. And also, as I said, the HER2 expression is most often seen in the proximal stomach, and which also includes your GE junction rather than the distal stomach. And distal stomach, most often we know, are polycohesive or the signet ring cell type of adenocarcinomas that we see. The other trial that happened, which actually brought about this heterogeneity, was again the phase 2 Destiny Gastric 01 trial, which actually matched archived biopsy samples versus fresh tissue samples. And then they realized that it could happen vice versa, that HER2 positive cases could become negative on the fresh samples, whereas few cases could also turn into positive cases. And hence it becomes imperative for us as pathologists and oncologists to understand this and try testing as many samples during disease progression as possible. Look at this. You have a variation in the HER2 status between the primary and metastatic setting. So when we're looking at this, we have negative conversion and we have positive conversion. So what is negative conversion? Negative conversion is when we have an adenocarcinoma which expressed HER2 new initially, but it was completely negative in a lymph node metastasis. Or positive conversion when we have an initial adenocarcinoma which was negative for HER2 expression, but later turned out to be positive during metastasis setting. So you can see that there is some percentage of cases that are going to work in this manner, and you need to be aware of what was your primary threshold reporting of your HER2 versus the metastatic setting. So it becomes important to have the reflex test in context to this scenario. Now, how do we overcome this heterogeneity? So we have to have some methodologies or some principles that we all can apply in our laboratories, and also see how best we can try to reduce the heterogeneity and see which patients are actually getting benefited by the anti-HER2 treatment. So few recommendations are there where we can look at ruling out all these false negative results. One would be that we need to have the most representative material, and hence the biopsy has to be done from different areas. So we know that the intestinal type is going to express HER2 and the diffuse type is not going to express. So if your tumor has both types of areas, then it becomes imperative for your endoscopist or the gastroenterologist to see that and sample multiple areas rather than sampling a single area. So there you can have a wide variety of mixture of population, especially for these heterogeneous cases. Homogeneous cases, we are not so worried because it may show entirely the similar picture. But will the endoscopist know or the gastroenterologist know that it is heterogeneous? Obviously not, but they have to try and sample as many bits as possible from different locations of the tumor rather than a single site. The other point, no cases should be considered HER2 negative without IHC examination of at least 3 to 4 slides. This is a slightly controversial point. I was going through this article a few weeks back, and then they clearly say that in this particular article, where they studied mostly the resection specimens, and they went ahead and in case the resection specimen, they picked up one slide and they saw that it was negative, they have rerun the HER2 new on few other slides and have picked up a percentage of cases which has actually turned out to be HER2 positive, and hence the patient stood the benefit of treatment with trastuzumab. Now, are we able to do this in our laboratory? It is a big question mark. I hope this gets addressed in the panel discussion, because I don't think many of our labs try doing 3 or 4 slides or multiple repeats unless and until we see the morphology clearly and we try to deem this case as extremely heterogeneous. I don't think this is a call that we actually take, but this is a recommendation that has been given in one of the papers. And obviously, you will have to have reflex testing in cases of your equivocal situations, or even when you feel that there may be certain cases where there is some non-specific staining of the tumor cells. So in these situations, a concurrent use of your IHC along with ISH test definitely helps. And here, ISH can either be bright field ISH or it could be fluorescent ISH. It really does not matter, because now we have FDA approved kits for your bright field ISH as well. So the high degree of heterogeneity, it's actually considered as an expression for progression of the disease following HER2 targeted treatment. So we have two scenarios. We have homogeneously HER2 positive gastric cancers and we have heterogeneously HER2 positive gastric cancers. So what do we mean by homogeneously HER2 positive cancers? The entire tumor, you may have tested it on your endoscopic specimen or later on your resection specimen. You realize that this tumor shows uniform positivity, what you see maybe in your breast cancer cases. Similarly, you're going to see all tumor cells are uniformly stained and they are showing overexpression of your HER2, or there is a score of 3 plus HER2. So in these patients, they saw that there was a longer survival with a median progression-free survival of 10.8 months. But look at this situation where here it reduces. Your PFS and your OS reduces drastically in your heterogeneously HER2 positive cases. And here They also saw that the tumor shrinkage post HER2 treatment was almost 49% compared to 40%. That is because here there is obviously going to be more cells expressing HER2, and your anti-HER2 treatment is going to be really effective in targeting and causing a lot of tumor cell death when compared to heterogeneous tumors where you still have a lot of viable tumor cells which are non-HER2 expressing. And hence, there is going to be a lot of residual tumors in these situations. Now, the importance of retesting is something that needs to be addressed. We all know that most of our labs now, because of a lot of education programs and a lot of CAP protocol updates, etc., we are all doing the testing. But are we actually doing this retesting? That's a big question mark. And how do we do retesting? Why do we need to do retesting? These are important questions that need to be answered. This is like maybe we have entered into the next zone of the HER2 treatment for gastric cancer, because how often do labs get requests for retesting? So that is again something that needs to be addressed, and we need to understand why retesting is essential. So these are few papers which actually saw that there was some amount of progression even in spite of the trastuzumab treatment for certain patients. So what was happening here? That was a big question mark which these papers tried to address. So you can look at this in one of these papers which was described. So 29.1 to 64% of patients developed loss of HER2 expression during treatment when it was already IHC HER2 3+ positive. So there was also downscoring which happened on a repeat testing. Maybe your 3+ became 2+, or 2+ became 1+, or a 1+ became 0. Now, what was actually happening? We had few other papers which also answered some of these questions, that because of trastuzumab therapy itself, it could change the gastric cancers. What is a big question here and the answer to that big question? So trastuzumab is going to target your HER2 expressing cells. Hence, it may cause or remove most of the cells which are expressing HER2 post-treatment. It's an obvious or a logical answer, correct? So when you have a post-treatment case, post-trastuzumab treatment case, which you're going to test, then these cells are already removed, yes, and you're going to see non-expressing cells, especially in case of your heterogeneous areas. So this is one of the reasons why there could be a change in the HER2 status. But also at the same time, we could see that some cases which were negative could also become positive. But this is obviously those cases were not treated with your anti-HER2 regimen. And also, there was a recommendation telling that retesting is required because there can be HER2 loss. This is because they realized that the tumor cells had acquired resistance to trastuzumab-based therapies, and this was seen almost in 1/3 of patients. And hence, for choosing your NHER2 treatment or your HER2 treatment, again, for these patients, it is imperative now that you retest either in the recurrent site or the metastatic setting. So this is an example of a biopsy which was HER2 positive, which again stands to be HER2 positive. This is known as persistent HER2 positivity. So this tumor, there is no obvious change, and the patient may respond very well with either your HER2 or anti-HER2 or your NHER2 treatments. But look at this case, loss of HER2 positivity. There is going to be almost null type of reaction or complete negative response here, and maybe a 2+ or a 3+ has become a 1+ in this situation. So these are cases where we could attribute some amount of resistance also happening to the treatment. So now where are we going to have the retesting recommendations being there for the pathologist? Mainly it is a borderline cases. Like, what do we define by borderline cases? We have a 1+ or a 2+ on the biopsy, and then you would want to repeat it on the resection specimen. It needs to be done because it again accounts for your tumor heterogeneity here in these situations, and also few of your problematic cases. Here, you need to understand that in gastric cancers, I have also come across in our own lab setting, we may have some non-specific nuclear staining. So we really do not know whether to call it as aberrant reaction or non-specific reaction, but either a cytoplasmic or a nuclear staining should be classified as equivocal because this is non-specific localization. We do not know the reason behind this, and these cases go in for your reflex testing. So these are few imperative situations where for borderline and problematic cases, you can take the help of your reflex tests. Also, cases with strong HER2 staining. So when you understand this strong HER2 staining, it is especially in your surgical specimens or your resection specimens. We know that in case of certain heterogeneous situations of the tumor, sudden staining or very high degree of 3+ staining you're going to see, it is better confirmed by your reflex tests of your ISH, which could be again FISH or your bright field ISH. So these are situations where you need to consider these as borderline and problematic cases and go ahead and try to do a reflex testing and then give a confirmatory report to your medical oncologist telling this is either HER2 amplified or non-amplified, where they stand the benefit and the answer is already given to the oncologist. Look here, this is a confident report I'm giving at my end, and you can go ahead with either giving a treatment of trastuzumab based regimen or non-trastuzumab based regimen. This becomes very important. Now let us move on to the lab and we'll see how to test and interpret the test results. So sampling is very, very crucial, and it is the an early determinant because this is going to actually lead to the accuracy of your HER2 testing. So first of all, we all discussed and we all now came to know that, okay, now the tumor is very heterogeneous and things like that. So how are we going to overcome this heterogeneity? As I already mentioned, the minimum recommendation is 6 to 8 biopsies that is required from the or gastroenterologist end. So it becomes more like a teamwork here. You have the lab, you have the gastroenterologist, you have the medical oncologist and your surgical oncologist. So it's a team effort, and you need to educate your surgical oncologist and your gastroenterology team that you need at least 6 to 8 minimum fragments of tissue from different areas of the tumor to overcome the heterogeneity, and also so that we can have more pickup cases of the HER2 positive expressions. So once the discussion is done and you start getting these, you need to also reduce the errors. So one is you need to tell them that the necrotic areas have to be minimized, and they need to take as far as possible tumors with less areas of hemorrhage, necrosis, etc. And these tumor tissues are then immediately put into formalin, because we all know a lot of pre-analytic errors happen in the lab, and these can lead to false negative reports, or we can also get a lot of non-specific or aberrant stainings in the report, which will really become difficult for the pathologist to interpret. And hence, you need to maintain the cold ischemic time, and recommendation is that within 20 minutes of the endoscopic biopsy being taken, it has to be shifted into formalin and sent to the laboratory. Tissue microarrays should not be dealt with. Especially some labs may have the thing, okay, now if you want to do your FISH, we know how costly the probes are. You want to mark out a small area on your resection specimens, or it may be on your endoscopic biopsies and things like that. You want to put in 1 or 2 tissues more on that slide. All those things are not going to happen in case of your gastric biopsies or your resections, because the tumors are heterogeneous and you need your entire section being sent and tested for either your IHC or for your ISH test. So because of this, please note that you cannot use microarrays for your samples. And if it is not possible for you to either have a resection sample or an endoscopy sample, cell blocks are accepted for your HER2 testing, provided that you have done your lab validation. So without that, you cannot be testing your HER2 new on the cell blocks. So we all know we have stringent accreditation norms in place in the lab, and you need to follow these and practice, have a good lab practice at all times. So without that, you cannot test your cell blocks. But otherwise, if you have done a good validation and your cell blocks are working fine, you can use cell blocks either of your metastatic fluids, etc., where good cell blocks are prepared. These can be taken and tested for your HER2 and interpreted. Now the question is whether IHC is good or ISH is good. So we all know that IHC is a cheaper test when compared to ISH, and not all labs have the facility to have or process the ISH, right? So upfront, most of the Indian labs that I'm aware of are doing the IHC testing, but you also need to have a reflex ISH testing. As I said, the problematic cases need to be dealt with, and you'll always have problematic cases in your labs, and ISH testing becomes must and should. So here nowadays we also have the bright field ISH, which has come into picture, and many labs are already doing it, so you can have it. Only thing is the in situ hybridization is going to take a longer time, but there's no hard and fast recommendation that all your samples have to go into ISH testing. It only depends on your equivocal results. So the other question was, now why did we get the scoring pattern of gastric cancers being different from breast cancers? We could have used the breast cancer criteria itself, right? No, but that is not applicable to your gastric cancers because gastric cancer cells are more gland forming when compared to your breast cancers, and they have a different aspect of staining, which is totally different from your breast cancers. Breast cancer, when we define 3+, we say complete strong membrane staining. And it's that chocolate brown staining which you're seeing in these images here. But the same complete membrane staining is not applicable in your gastric cancer, as these are gland forming. And for us, even a good 3+ staining of the basolateral staining or lateral staining is taken as 3+ intensity, and it is given as a positive result. And the other thing that you need to remember is we have different cutoffs for gastric as well as breast cancer. In breast cancer, it is more than or equal to 10% of cells, which is both applicable to your resection and your biopsy specimens. But in gastric cancer, since the amount of tissue sampling itself becomes less and it is tedious job, so here we have a cluster of 5 or more cells which are considered as positive. And on resection specimen, your threshold increases to more than or equal to 10% of cells which show 3+ staining, which is not necessarily complete, but it is definitely strong intensity. So this is what you need to remember. So this is what is defined as your circularity. So circularity of the tumor cells is most often missing in gastric cancers, and you should not call these cases as equivocal or try comparing it with the breast cancer. And you need to do a lot of tests and try to have your own learning curve on calling which is positive and which being equivocal. Look at this nice cartoon that we have here. It actually explains your lateral membrane staining, your complete membrane staining, your basolateral type of staining. So most often, see, this complete membrane staining is very rare that we get in gastric cancer, but you need to have an idea of what complete membrane staining is. Your basal, your apical, and your lateral aspects, the entire 360-degree portion of your cell undergoes the staining. Your lateral membrane staining is between two cells. All right. So it is not your basal. We are not looking at the basal. We are not looking at the apical aspect, but we are looking at the lateral aspect where the cells join each other. And you have to see the staining or these lines in between the cells, in between your tumor cells. When we look at basolateral, we are looking at the basal aspect of the cells. We are leaving the luminal aspect completely over here. And we are seeing that the lateral aspects are stained along with the basal area being stained. So these are the patterns of staining that you're going to get in your HER2 staining in your GE junction and gastric cancers. All right. So these are what are termed as your 3+ cases. And this is an example of heterogeneous staining. So you can see, you can actually count 1, 2, 3, 4, 5, 6, 7, 8, 9, maybe around 20 cells are stained here, which are almost 3+. But over here, you can see 1, 2, 3, 4 cells, and the rest are showing 1+ or 2+ staining. So in a same tumor, you can see 0, 1+, 2+, 3+ reactions when the tumor becomes heterogeneous. So this is an important table to remember, and this is nicely elucidated even in your CAP protocol for reporting. So here you can see both your surgical specimen criteria and your biopsy specimen criteria. You need to have 2 negative scores, which is your 0 and 1+, 2+ and 3+. Please understand one thing, even my colleagues keep asking in the laboratory these days, we have so much of this low, ultra low, everything coming into picture. It's causing a lot of confusion in the laboratory. We have still not come to that low, ultra low, null situations in the other solid tumors. It is predominantly for the breast cancers. Here we are only calling it as negative, equivocal, and positive. We are not bothered about the any scoring pattern or any descriptions of low or ultra low. Maybe we may enter a scenario like that, but right now we need not worry about it. So once you know that you're giving a score of equivocal, this has to be compulsorily subjected for your ISH test. And this not only includes the criteria described here, but also the criteria that I said of non-specific cytoplasmic and nuclear staining also should be tested with a reflex ISH test, which is very, very important. And the next question for the pathologist is, what are the clones? What is the platform? So it is always better to use an automated platform, because most of these are becoming companion diagnostic assays, and we do have good comparability between clones. We have various clones in the market, and the FDA approved ones are obviously your Hercept test, that is your DACO clone, and then you have your 4B5 from Ventana, which are FDA approved, and the rest, when you're using, you have to lab validate them. They will become your LDT for reporting your GE junction and your gastric cancer cases. So for your LDT, you already know that it is about 40 positive, 40 negative cases. And then for your FDA approved test, it is 20 positive, 20 negative cases. Now, since this is HER2, you need to have a good spectrum of your negative cases, your equivocal cases, and your positive cases. So in your lab, when you're doing the validation, you should also use your reflex test for completely validating. That is, all your 2+ cases have to be sent for ISH. Your 3+ cases also have to be sent for ISH. Maybe you could pick out few cases and then send it, and your negative cases. So you know that your negative is actually negative even on ISH. Your equivocal may have been positive or negative, and your 3+ has to be positive on your ISH. So this is how you do your entire spectrum of validation when you're trying to do. And also when you're changing clones, say that you have a LDT clone. Now your lab is upgrading to an FDA clone. Again, you need to do a clone comparison between already known cases, and you need to document this in the lab for your accreditation. This is not just for your accreditation. This becomes part of your good lab practice. Now, when we come to procedural deviations, there are a lot many, and most of it is addressed. Now, the labs are very well aware because we have strict guideline recommendation. Since already it was done for ERPR HER2 of breast cancers, the same is applicable for your specimens of GE junction and gastric cancers as well. So as far as possible, avoid specimen drying. So when small biopsy grossing happening, close the cassettes immediately and put it into formalin. The type of fixative has to be 10% neutral buffered formalin. There is no excuse on that. Then the temperature, storage, and pH, everything has to be monitored in the lab. You need to have a pH meter. pH paper is not sufficient. So you need to have your pH meter and check the pH of your fixative very often. Either acidic formalin or alkaline, too alkaline formalin is going to cause hazardous results for your IHC interpretation. The length of the fixation, because these are GI endoscopic biopsies, generally anywhere between 6 to 24 hours would be recommended, but not more than that. And resection specimens, you have an interval of up to 48 hours or maybe extend up to 72 hours. And this becomes important. Your processor should have good reagents. That is again important. And change of reagent log has to be maintained in your lab. Then your storage of paraffin blocks and cut sections in a good environment is required, because you may want to test a sample which is 2 years back and sitting in the archive, and then you may want to test your HER2. So you need to see that there are proper storage conditions which are there. Please do not use prior cut sections for your IHC, because that is going to cause a lot of negative results. So use always freshly cut sections, and if you can keep some cut sections, but not anything later than 6 weeks and beyond. So section thickness recommended is 4 microns. So that is what needs to be given as education to your technicians. Turnaround time is important. So it is already we have our own lab defined turnaround times, and there should not be any delay in reporting the HER2 cases, because the patient stands the benefit of treatment in the positive cases. So this is basically a multidisciplinary coordination, as I said. And when do you do the testing? You should know, your surgical team should know, your medical oncologist should know. And what is the turnaround time has to be explained clearly to your oncologist. So one other thing is, try as far as possible not to give an inconclusive report. Whenever you have a 2+, try to establish what is it exactly, post your ISH, and then give a confirmatory report. And also, as I said, automation is important in the lab, and you need to have good automated stainers. Otherwise, you may land up in problems in having the FDA approved clones and testing them. So this is how a good pathology report will look like. And this is actually from the CAB biomarker template. So you can have this in your lab as part of your reporting protocol for your HER2 biomarker testing. You can give your scores as 0, 1+, 2+, 3+, and then you also, if you have done any reflex test, you can explain what it is. And the reflex-ish test, if you are already into the practice, then these are the summary that you need to give. The HER2 sep ratio has to be mentioned, the HER2 signal per cell, the average number of sep signals, and then finally you give your calculation. And if then any other test, maybe your bright field dish may not have concluded positively, so then you may have to do your fish as well. And you also need to mention whether it is a single or a dual probe assay, or any further genomic testing has been done. And you need to choose whether it is FDA or your lab derived test that you're using in the lab. And this would be a very high quality report, standardized report format, which is very easily readable by the medical oncologist without any difficulties or apprehensions. There'll be no second questions. And even if the patient goes elsewhere for treatment, seeing the standard reporting format becomes very easy. So coming to the key takeaways, we know that HER2 is expressed in gastric cancers, and we see 12 to 20% of these cases, especially in gastric cancers, and 30% to 33% in your GE junction. And for sampling, we need 6 to 8 biopsies, which is very, very crucial, and where there needs to be an education between the gastroendoscopy room to the pathology lab. And you also need to understand these tumors are notoriously heterogeneous, and you may have to keep repeating the HER2 test in between during the course of treatment, or in case of recurrences or distant metastasis. So whenever you see difficult borderline cases, take another review by your colleague. And it is always nice to consult with someone else and be confident on your report, and also take the help of your ISH tests. So ISH can either be bright field or it can be fluorescence. So thank you. With this, I end my talk. I'll stop the screen share here, Rukmini.
Ma'am, yes. Thank you, Dr. Vidya, for that excellent and enlightening presentation. We now move to an interactive panel discussion titled HER2 in Focus, Testing and Interpretation for Superior Gastric Cancer Outcomes. It is my honor to introduce our moderator, Dr. Subbalakshmi Sengupta. Dr. Subbalakshmi Sengupta is the head of Department of Oncopathology at Manipal Hospitals. With significant expertise in oncopathology and diagnostic pathology, she is known for her precision, academic involvement, and contributions to improving cancer diagnostics and patient outcome. I now hand over the session to Dr. Sengupta. Ma'am, the floor is yours.
Good evening. Am I audible?
Yes, ma'am. Yes.
Okay, thank you. Thank you so much. Thank you to the organizers for offering me this session, and a warm welcome to the panelists. Next slide, please. So, may I introduce the panelists today? Dr. Rukmini Besbarua. She is belongs to the Department of Oncopathology, Dr. B. Barua Cancer Institute, Guwahati. She is an associate professor over there. Next slide, please. Dr. Arpita Sutradhar, Senior Consultant and Sectional Head of Histopathology, Apollo Multispeciality Hospitals, Kolkata. Dr. Anand, a Consultant, Department of Pathology in Tata Medical Center, Kolkata. Dr. Saurav Bhaumik, a Section Head, Department of Histopathology and Cytopathology, Suraksha Diagnostic Limited, Kolkata. And last but not the least, Dr. Paulami Basu, Medical Oncologist, Netaji Subhash Chandra Bose Cancer Hospital, Kolkata. So after a nice and elaborate talk of Dr. Vidya, so I want to just summarize what are the takeaway points once more. So HER2/neu is a proto-oncogene of EGFR family whose phosphorylation initiates the signaling pathways that lead to cell division, proliferation, and differentiation and apoptosis. HER2 gene is expressed in normal epithelial cells, and its amplification or overexpression has been reported in breast cancers, as we all know, and gastric cancers. The overexpression of gastric cancer varies with histologic type and differentiation, and it is extremely heterogeneous. And the way we report HER2/neu in gastric cancer is very different from how we report in breast cancer. So with this background, can we move ahead to the panel? Next slide, please. Next slide, please. Next slide. So, the most prominent difference that we encounter while reporting HER2 in gastric cancers in with respect to breast cancer is that the tumor heterogeneity we have come across in our daily life. It can be the tumor can be heterogeneous both in the resection specimen and the biopsy endoscopic biopsy specimen. So HER2 is amplified or overexpressed in 12 to 20% of gastric carcinoma cases. In intestinal type, about 30% of their cases show overexpression, while the diffuse type 5% cases of diffuse type show overexpression, and HER2 is amplified or overexpressed in about 33% of GE junction cases. Now, next slide, please. My question to Dr. Paulomi, what percentage of your gastric carcinoma cases are diagnosed as advanced gastric cancer?
I must say around 60 to 70% of the case present in a very advanced stage due to lack of awareness. Mostly patients present with a very advanced stage, around 70%.
Okay, and do you routinely test all gastric cancers for HER2
Yes, we routinely do HER2 testing for all patients at big time because now we have enough data that if it is HER2 positive, we can use trastuzumab. So we routinely do HER2 testing for all gastric cancer patients.
Okay, and how many cases? I mean, what is the prevalence of HER2 positive gastric cancers that you come
So we
across?
know, yes, actually we know the incidence of HER2 positivity is high. But in our practice, I think only 10% of cases we find HER2 positive, maybe due to inadequate sampling or maybe mostly due to inadequate sampling. For proper techniques, we only found around 10 to 12% positivity rate.
So when you find HER2 negative gastric cancer, that do you go back to the pathologist and ask them to repeat, or ask the
No,
endoscopic gastro
actually, we
surgeons
all
to
know
repeat a
that,
biopsy, endoscopic biopsy?
yes, actually, adequate sampling is very important, but mostly I think 6 to 8 for means sampling is important. But mostly in our center, due to some issue, I think mostly because of this inadequate sampling, there is more false negative result. So I think, but yes, repeat HER2 testing we not routinely do. If yes, if disease progressed, patient already on trastuzumab and then progressed, then only we repeat HER2, we do repeat testing.
Okay. So my next question is to Dr. Anand. So as we know, gastric cancers are highly heterogeneous in terms of HER2 expression, depending on the histology and where the tumor is located. And what, according to you, are the best practices which various medical specialties should adopt to ensure that HER2 positive gastric cancers are identified reliably?
So, a
What
very
is
good
your
evening.
practice in the lab?
So, a very good evening to everyone. Yes. So, as has already been iterated by Dr. Vidya Madam in her talk. So, first thing is these gastric cancers are very heterogeneous. The HER2 expression is very heterogeneous in the gastric cancers. So, if we start from the first level, the endoscopy should the gastroenterologist or the person who's doing the endoscopy, he should take biopsies from multiple sites of the tumor, so to ensure that we don't lose on the heterogeneity of the tumor. Second thing is should come about is the fixation. The fixation should be done very nicely so that to ensure that there is proper immunohistochemical expression of the tumor cells. Then third point which we come across is what we should ensure is that we use standard antibodies, standard immunohistochemical procedures for staining. Of course, automation ensures standard of care. In our hospital, we do our all ICs are being are in the automated machines, so taking to all these things, if these factors are looked upon, then we can ensure that there is a reliability. And of course, on the interpretation part, the pathologist must be well trained and they have a learning curve, and accordingly they should interpret it. Whether it is especially this is especially important in the borderline cases, and especially in gastric cancers where we have to interpret even the basolateral staining and give them appropriate scores.
Thank you. Next slide, please. So I'm not going to into the details of this slide, as we have heard that these gastric cancers are notoriously heterogeneous. The same tumor can be negative as well as 3 plus positive. So going to the next slide. The question is for Dr. Rukmini. In what aspects is biopsy in gastric cancers different from breast cancer? So if you just can elaborate on that in terms of technique, location of the tumor, amount of tissue obtained, and inconvenience to the patients, etc.
Am I audible?
Yes, yes.
Yeah. Dr. Vidya ma'am has already told that it's quite different from breast because in case of gastric cancer, we see glands. So right from the tumor heterogeneity part is also different. So we need more number of cores from different areas, which will be representative of the, because sometimes we might have a tissue which might have a negative HER2, but in other part it might be a 3 plus core. So in order to have a representative HER2 scoring, we need more number of like tissues from different areas. And as we have already known, that's more common in the proximal part of the stomach than the distal part. So these things should be considered. And that is how it's different from breast. And even the scoring is also different. We apply a different scoring system, and which is also different for both biopsy as well as for specimen.
Resections.
Because so that's how it's different.
Right. Dr. Arpita, from your experience, what steps will you take to improve the accuracy and reliability of HER2 testing in gastric cancer, including sample collection, test interpretation, and avoiding common pitfalls?
Yeah, good evening to all. To begin with, the gastric tumors, they are endoscopic biopsies. So, in case of breast, we have an added advantage that the tumor is like we can directly hit the tumor and they are bigger, in fact, since we can get more cores. If we our role in as pathologists starts from once the specimen reaches to us in the lab. So our role starts from right from fixation. Like we have to make sure that the pH and the dilution of the fixative we are using is appropriate, like 10% neutral buffered formalin. I repeat, it should be buffered because the pH and the dilution both will affect the uh, interpretation and expression of HER2 in the biopsy specimen. Next is, like as discussed already by Dr. Vidya, the sample processing in the department. Histopathology, it is unique in the sense because we have a chain of process. One process affects the other. So the quality control measures, they might be not so precise like in biochemistry lab, but still we have to maintain and look into the thing that the machine, the processor, the reagents, everything is up to the mark and they are maintained in the good quality. Next, coming to the like running the immunohistochemistry on a platform like manual or automated. Definitely automated is preferred over manual, and the using the type of antibody. So as she said already, Dr. Vidya, that Hercept and 4B5, they are the FDA approved antibodies. So it's better we because all the studies are done on those FDA approved antibodies. So it's better we use those two antibodies and definitely automated platform. So once we make sure that these standards are followed appropriately, next comes the role of the pathologist as interpretation. So interpretation, again, if we work like if inter-observer variability, we all know it's more in 1 plus or 2 plus and less in 3 plus. So yeah, the cases of 1 plus or 2 plus can always be subjected to, like, you can share the slides with a colleague and get a better result. So I think these are the ways we can make sure that the outcome, the efficacy on like avoiding the common pitfalls in HER2 expression.
Right. Just a quick question. Are we all using automated platforms, all the panelists that we have now
Yes.
on the panel.
Yes,
And
we do
what
have.
antibodies are you using?
Ours is Ventana platform and we use 4B5.
Right.
We also have
Dr.
a 4P5.
Yeah, we
We
also
have
Right.
a
using the
Ventana
same
platform.
antibody clone and the Ventana platform, and it's automated.
I use a LDT actually.
Right. Next slide, please. Now, this is an open question. What coordinated workflow can reduce discordance between pathology results and clinical expectations in gastric cancer? And what is the minimum number of biopsy cores required to confidently identify or rule out HER2 positivity or overexpression in gastric cancers? Dr. Saurav, if you can take the question first.
Very good evening to all, and thank you, the organizers, for inviting me for this esteemed panel discussion. Yes, what coordinated workflow can reduce discordance between pathology results and clinical expectations in gastric cancers. That is actually, it's as already Vidya Madam told, it's a very good team effort is needed, and I starting from the endoscopist who is giving the biopsy to us, and from the or the surgical GI surgeons who are giving the blood specimens to us, then the pathologists who are deciding the what portion of the tumor should be taken for the this testing, HER2 testing, and further the processing, the fixation, also the interpretation. So right from the very first, and from the endoscopic point of view, at least it has been already repeatedly told that we should take at least 6 to 8 good cores of the tissue from the tumor directly, and avoiding the necrotic or hemorrhagic parts. That's the tumor should be viable area, and we should judge the adequacy of the sample from the after seeing the slides and after proper processing, and it should be processed within cold ischemia time should be minimized as far as possible, so that it can be given to the ferment within 20 minutes, or for the large specimen it should be up to the 1 hour time, which is the recommended cold ischemia time. And after receiving the lab, we should properly fix the tissue for the 60 to 24 hours, and after getting the samples, we should do the proper processing. The section quality should be good, and for the HER2 testing, we should thoroughly follow the whether it is LDT or the FDA approved clone, whatever we should use. And if we use the LDT, it has to be thoroughly validated, and it has to be corroborated with the each results, and so that we can be confident that what we are delivering is adequate, is good quality report. And we should follow the proper ASCO-CAP guidelines for the interpretation point of view, and it is definitely very much different from the breast HER2 reporting. And here it is no such like 0 plus 1 plus or 2 plus criteria. There's a low or ultra low portion. It is definitely the HER2 the reporting pattern which is recommended by ASCAP, it should be adhered on. So that if we go through the proper protocol, then this discordance can be minimized a lot, I think.
Dr. Rukmini, how would you place MDT discussion? How important MDT discussion is in interpretation of HER2/neu? Um, what is your opinion?
I think if there is any discordance, and then definitely we should discuss with the clinicians. I mean, if they were expecting a HER2 positive tumor and we haven't got it, maybe we can ask for a repeat biopsy. So I think it's very important in case of discordance.
Dr. Anand, what is your take on that?
Yeah, it's important. First, like the learning curve should be there for interpretation, because over here we have to really get to know the basolateral staining is present or not. And secondly, if there is any discordance, I think a second opinion from your colleagues is very important in that. And one should also know how to decipher of granular staining. Sometimes they're granular staining, and as also said, sometimes they're nuclear staining. So should also try to ignore those as well.
So, do you discuss every HER2 negative case in MDT and take it from there? I mean, how to, whether to retest or go for a biopsy?
No, in a MDT group, if it's a HER2 negative case, usually we don't discuss that much until unless the patient is again progressing and then he is progressing even on treatment, then they might be take a site from other metastatic site. They can take a biopsy and then again retest for HER2 if there is the patient has gone to palliative therapy. So in order to give him options for treatment, sometimes we can do that. But as such, if it is a HER2 negative case, usually we don't go for so much in the again for thorough retesting the patient again for that any HER2 positive case.
Dr. Arpita, what is your experience on that?
See, honestly, I'll tell you, although I work in a corporate, but in India, the scenario is let's be more realistic. Like the patient, first of all, there's a loss of follow-up. And next is like, even if the patient gets HER2 testing done once, I don't think the patient allows us, or we get a biopsy fresh, we have the legacy of getting a biopsy, again, a repeat biopsy only for HER2 just to make it turn out to be positive. So practically speaking, if we give it a outright negative, we don't get any repeat biopsies for just for the sake of like getting it positive from the other side. And again, that is absolutely the discretion and choice of the consultant,
Right.
whoever is like treating the patient. But then, yeah, in dubious cases where it's like 1+ or 2+, or something like where we can, I think, resort to like a different site, metastatic site, or maybe a lymph node. So we can just suggest. But again, finally, the deciding factor becomes the cost and the patient.
And also, I would like to add one point. Since we some of us work in like standalone labs, we do not have that luxury of having an MDT, and we
Right,
it is
right.
uh, except but we cannot like get across to the surgeons many times. So I feel that is also a constraint that we have.
Yeah,
Right.
Absolutely.
completely agree with you.
Dr. Polami, should HER2 testing be repeated at every progression point or only when treatment change is being considered?
No, I think we should retest HER2 testing because we know there are some chances of HER2 loss. And if patient already on trastuzumab and again progress, if we plan for TDXT, so before planning, we should retest whether it is positive or negative.
Okay. Next slide, please. So, this slide shows the variation in HER2 status between primary and metastatic samples. And we do come across cases where there is a difference in HER2 expression in the primary and metastatic samples. In some cases, there may be negative conversion and there may be positive conversion as well. And changes in HER2 status between primary gastric cancers and matched synchronous metastasis were observed in 9.26% cases. Now, next slide, please. Again, a question to Dr. Polami. Considering that HER2 expression levels can change between primary and metastatic sites, how should the sites be selected to acquire tissue for HER2 testing, like upfront?
Yes, yes. Actually, there are some discordance rate, which is around 10%. So I think
You're not audible.
am I audible? Am I? Hello?
Yes.
Yes,
Yes,
you
ma'am.
are audible. You are
Yeah,
audible.
yeah. So I think there are some
I'm not
discordance
able to
around
hear Dr.
10%.
Polami. Is it my problem or like everyone can hear?
Yeah, we can hear your
We can hear
voice.
both of you.
Okay.
We
Yeah.
can hear both of you, yeah.
I think there
I
are some
just can't hear
discordance.
you.
Okay. Now I am audible.
Your voice, both of you are audible.
Yeah. Okay. Thank you.
Yes, please carry on.
Yeah, please carry on.
Okay.
Sorry. Yeah.
So I think there are some discordance, around 10% discordance rate. So we should face from most accessible, most progressive metastatic site for HER2 testing.
Okay. Next slide, please. Have the panelists observed loss of HER2 expression post primary trastuzumab treatment in their practice as well? So, Dr. Paulam, if you can take that.
Yes, yes. Around 10% of cases, if patient already on trastuzumab, there is evidence that patient may lose HER2 expression. So that's why we do repeat HER2 testing after progression on trastuzumab.
Dr. Anand, how often do you get a request for repeat HER2 testing after a trastuzumab treatment?
To be honest, we don't get much after like trastuzumab treatment. Again, a repeat HER2 testing, and we don't get that much. Maybe it will be around
Same here, same here.
5%
I
to
also do not get
we don't get
much
that
of,
much.
yeah. Dr. Rukmini,
Yes.
so how often do you get requests for repeat HER2 testing after trastuzumab therapy?
On my personal experience, I haven't got any case up till now.
Okay, okay. So
Maybe I
next
think
slide, please.
it is quite recent that people have now started giving HER2 in advanced gastric cancers. So maybe after 1 or 2 years, we start getting after a particular period of treatment, the patient may progress, and then we can get a repeat testing for HER2.
Right.
Probably if we have some, I feel there is discordance between the biopsy morphology and the large specimen. So in that case, maybe like we might go for retesting, even if the clinician doesn't ask.
Exactly, I
Suppose we
agree.
have a signet ring morphology. If it is not actually a signet ring, we just have like if it is a mucinous tumor. So in those cases, in small biopsies, the score might not be correct. So in that case, maybe in large specimen, we can get a retesting done, and we can
Yeah,
suggest that.
yeah. No, I was asking after trastuzumab therapy, does your oncologist request you to repeat a HER2
No, I
Not really.
haven't received it.
Okay. Yeah. Okay.
To be very
Okay.
frank, it is actually very difficult to answer because in many cases we don't know whether it is a post-trastuzumab sample or not. Because as we are working, I am working in a standalone laboratory, and many times we don't get the detailed history of the patient, that whether this patient already received trastuzumab and this biopsy is taken after the trastuzumab therapy or not. So it is
Right.
difficult to state from a standalone laboratory point of view.
Yeah, it's
And
practically it sometimes becomes
prac-
very difficult.
practically it's difficult, but
Yes.
yes,
Yes.
from if it is in a hospital practice and where we can see the whole case scenario, we might get that history that this patient has got a trastuzumab therapy, and after the disease progression, the repeat biopsy is being sent for testing, retesting.
Right. Dr. Arpita, do you get that request in Apollo?
No,
No,
no.
not really. Okay. 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 So next slide, please. Dr. Paulamy, considering the reported loss of HER2 expression in gastric cancers post-trastuzumab treatment and the Destiny Gastric 04 results recently read out at ASCO 25, would you consider doing a fresh biopsy to retest and rescore HER2?
Mostly for if means disease progressed, we usually do repeat biopsy. But yes, there are some affordable issue. If there is no financial constraint, we routinely do rebiopsy before giving TDXD in second line.
Okay, so you will recommend a repeat biopsy before initiating the second line of treatment.
Yes.
Okay. So next slide, please. Uh, Dr. Arpita, Destiny Gastric Trials used HERCEP test DACO-assay to score HER2 expression levels. However, different labs may use different commercial assays or lab-developed tests to test HER2 in gastric cancers. Do you think does this have any impact on selection of eligible patients for the second line treatment?
Definitely it will have impact because as I said earlier, the problem or the trouble creators are cases which are negative 1+ or 2+. So and the issues like see Hercept and 4B5, these two molecules, FDA molecules, since they are standardized and they are standardized on an automated platform, right? Not on a manual platform. So the variabilities which we come across when we process the thing manually or with antibodies which are non-FDA approved, the variabilities in order to standardize those things, like you have to have a proper lab developed method, which is again quality checked by different ICAS or interlab programs, so that you make sure that you don't have any pre-analytical issues. Like analysis comes afterwards, but to do away with these pre-analytical aspects, we have to be more stringent and more precise in designing the lab developed tests with uh, the non-FDA approved markers and the manual platform. So otherwise, we won't be able to, like, we may lose many cases, which may actually might be possibly positive for her too, and it may not have turned out to be positive running it on a manual platform. And more so, like if you talk about the things like as Dr. Anand said, the granularity and things like that. I believe when you run it manually, the integrity of the tissue or the variabilities like in the processing, they are so like they are enhanced, so the background uptake or the granularity, things like these, they become like more troublesome if it is run on a manual platform.
Right.
So what I
Dr. Sor,
believe is, yeah,
yeah, no, please continue.
so what I believe is, like, if you don't standardize the pre-analytical aspect, like the platform
Again,
and
there
the
is a
molecule.
practical issues, practical aspects to it. Say we get us no, who those who are working in the hospital settings or an institute setting, that's different. But there are many labs who collect samples from far away, and these
Absolutely.
pre-analytic
See,
errors
that
are
is the
not
problem.
in
Like
our control.
mostly the expressor markers or the hormonal markers. Like these markers need to be like run more like on a standardized platform, because as you said, like if in a standalone lab, the samples, they travel a lot, and the fixation time or the cold ischemia time, nothing is being
We
able
do
to be
not know
maintained
about
properly.
them at all. We do not have
Yeah,
any
yeah,
idea,
exactly.
absolutely.
So
When they
getting
were
those
taken, when they
blocks,
were put into the formalin, and we do not know.
exactly. So getting those block tested for these expressor markers, like on which therapy is based. So that lands us like into trouble. Like we are losing might be quite a many cases because of that. So I know I'm very much aware of the scenario. Like this is actually the real scenario, but you can't just do away with those issues. Like you have to make sure for these expressors markers specifically that the cold ischemia time, the fixative used, the time spent in the processing, everything needs to be like standardized and like thoroughly uh, monitored and supervised. So if we can't make sure those things, we will always land into like false negative tests.
Right. Dr. Saurav, can you quickly please elaborate on what measures the laboratories should take to ensure that we get a reliable HER2 expression?
Yes, for if we do practice on LDTs, and it has to be very much very accurately validated, as Dr. Vidya already said, and as Dr. Orpita was also telling that. So, and we may use LDT for the HER2 testing, and because there is so much of pre-analytical aspects, and itself the testing platform as it is in the manual, and it is on the non-AT approved clone, and we have to validate it very thoroughly, and doing the proper interlaboratory testing and proper participate in the ICAS, and also the 2+3+ codes should be corroborated with the each results, and also the 1+2+ and 3+, that is this test should be validated with the different staining expression patterns. So then only we can use the LDTs and for giving the correct or accurate or reliable results. And otherwise, it's better to go for the automated platforms, and it is very easy to do the with the Deco or Ventura 4v5, whatever it is, and go for the FD clones. And because when we are going to the manual process, then it depends very much on the expertise of the technician who is doing the IC staining. In many cases, the IC staining technician is not that of a very good quality, and so many labs face the problem for that. Fortunately, I have a good technician, and I'm doing that for. I'm not facing any issue, but it is true that in many cases, and it is the big problem to doing the LDTs instead of the FDA approved clones. And so, if we do the LDT, it has to be very thoroughly validated. Otherwise, we should go to the automated platform.
Right. Thank you. Next slide, please.
One quick point I
Dr.
want to
Rukmini.
add, Dr.
Yeah,
Subalakshmi. So, in this
sure.
case, this problem with fixation and granularity is actually a very practical problem, which we face specifically in the outside review cases when we get. So, in that cases, we have
Absolutely.
recently, what we have done is we have tried to again reblocking it. What we do is if the tissue is good enough, it's in good amount, we melt the tissue, we melt the wax, and again block it in our paraffin wax. So sometimes it helps, not always, but sometimes it definitely helps in
Yeah.
But
improving
Dr.
So,
the.
Anand, will it
But if
change your processing part? Like you can reblock it, but
Yeah,
then
sometimes like ma'am,
fixation,
when we get that granular staining and all, the background staining is much more. So in that case, sometimes what happens is because of the paraffin, the quality of the paraffin wax is not that good in the block, especially in the outside block. So what we do is we melt it and we again reblock it in our own paraffin wax and blocks. So that
Yes.
actually helps in saving the tissue while cutting also, because our blades are all accustomed to that same kind of block size and all. And that also helps in this thing, the removal of the background staining as well.
but if fixation is the issue, that I
Yeah,
don't
if
think
fixation
can
is the
be.
issue, it's already gone. The ball is out
Yes,
of our hands.
because I
so
think the
I
most
think only if the blocks, if we feel that the blocks are not good and it crumbles, sometimes the blocks are so bad that it crumbles when you hold. So
yes,
then maybe reblocking may help.
yeah,
Otherwise, if
yeah,
the
it get fragmented.
fixation is gone, then
Yeah.
I
I
feel,
think the
Yes.
most
Some
important step is fixation. If that is hampered, I don't think even manual or
especially the
automated will.
resection specimens, the endoscopic biopsies still, I mean, these are small tissues. Sometimes they, I mean, do with bad fixation, I would say,
see,
but the resection specimens are very difficult to process if the fixation is bad.
if the issue is fixation only, then it is be it manual or be it the automated, the problem remains same. And if there is fixation issue, the automated platform will also face the same kind of problem as we are facing in the manual. Yes, as Dr. Anand
Yes,
said, that it
absolutely.
sometimes it becomes better that we also practice this chain, that changing the block and melting the block and reblock it, and so that the paraffin aspect can be overruled by this process only. And yes, we also practice that, and we definitely it gets a better result in some cases.
Dr. Rukmini, what is your biggest interpretation pitfall specifically caused by mucin-rich or poorly cohesive gastric tumors?
Hello.
Hello? Yeah, Dr. Rukmini.
Yeah.
Yeah.
So
So,
the pitfall in mucin-rich tumors, which I feel is false negative, is quite common in because of the deranged membrane, and because HER2 is a membrane stain. So we can get false negative results in case of mucin-rich or poorly cohesive gastric tumors. So, and that is an issue in small biopsies. That, as I said, if you have not adequate number of like representative areas, suppose we have only the mucin-rich areas, so we might falsely interpret it as negative. But if we receive a large specimen later on, we can see there are more glands, and that turned out to be positive. So that is, I think, the biggest pitfall while interpreting those areas.
right. Dr. Paulami, what is the minimum clinically actionable amount of HER2 positive tumor? 5%, 10%, or any focal 3 plus? Dr. Pauline, are you there? Uh, Dr. Pauline, are you there? I think maybe I'll take the question. Hello?
Oh,
Hello? Hello, Dr. Pauline, are you there? We go to the next slide, please. Um, Dr. Anand, do you routinely send her to IHC2 plus cases for in situ hybridization testing for gastric cancers?
Yes, if it is a equivocal score 2 plus, we definitely send it to the fish.
Okay, and what are the challenges you faced in your practice for ISH testing in gastric cancers?
The challenges are similar to what we see in the this thing regarding her to
Breast.
like again if the fixation is not good enough, even the fish will not be helpful in that case. Otherwise, I don't think so. We have any issues as such.
Okay, next slide, please. So this is an elaborate table stating how to interpret HER2-neu in gastric carcinoma. I'm not going into the details. Next slide, please. Why was a separate HER2 IHC scoring criteria developed for gastric cancers when we have a detailed HER2 scoring criteria for breast? Dr. Rukmini, if you can take that.
This will already been answered that in breast, the
Right.
morphology is different. In gastric, we have glands, and also there is more tumor heterogeneity. So, and so that in order to get more number of positive cases, we have a less percentage scoring system. In case of like specimen, we have more than 10% positivity is considered. While in case of biopsy, we take the number of cohesive tumor cells more than 5. So that is so a different protocol is applied in case of gastric cancer, and that's quite different from breast.
Right. Why are HER2 scoring criteria different for surgical specimens and biopsy specimens in gastric cancer? Dr. Arpita?
Yeah, if the reason might be like as said earlier, the biopsies they can be like from the necrotic or the hemorrhagic areas, and that may lead to an underscoring or a false negative interpretation. And surgical specimen like the tumor tissue, we have more definitely more tumor tissue, so the cutoff is 10%, and for a biopsy specimen is just 5 cell cluster. But like looking into the tumor quantity or tumor quantification, I believe that is the reason the scoring system is different. Like we have just 5 cell cutoff and there we have 10% cutoff.
Right. Dr. Saurav,
I think if we use can I answer this? I think if
yeah,
we
yeah,
have a
sure.
3 plus membrane, which we take for breast, I think we'll miss the number of positive cases. I mean, it will become very less for gastric cancers. So here, even the scoring pattern is also different. Basolateral and lateral is also considered. So because of that, we have a different from breast. And considering small biopsies, we might have very less amount of tumor tissue. So I think that is the only reason why it's different in case of specimen and biopsies.
Right. Dr. Saurav, if some labs are using breast-specific HER2 scoring criteria to score HER2 expression in gastric cancer, what is the impact in identifying eligible gastric cancer patients for the second-line treatment?
Definitely we'll lose some cases because as it's already been discussed that for the breast scoring we see the whole complete membrane staining, but for the gastric RT expression we see the basolateral or lateral are also considered as positive, and also the percentage is different. And for the breast it has to be more than 10% of the tumor cells, but for the gastric HER2, if it is a surgical specimen, it is 10%. But if it is endoscopic biopsy, only 5 cell cluster is sufficient to call it as a positive. So if we go by adhering to the breast criteria on the gastric HER2, then definitely we will lose some of the positive cases.
Right. Next slide, please. I'm not going to the details. We have elaborately discussed this. Next slide. Next slide. So, some of the Indian labs have reported very high HER2 positivity in gastric cancers, say about 40 to 50% cases. However, most of the other laboratories report HER2 positivity in less than 10%. So, this is an open question to all the pathologists. What do you think is the reason for such variability, and how much is the prevalence of HER2 positive cancers in your lab? And in the opinion of the panelists, what is the realistic HER2 positivity rates in gastric cancer? So, Dr. Anand first.
Yeah. So, I don't know about why they have got such a high positivity. If I talk of our institute, it's around 10%. It's not more than that, where we get HER2
Right,
positive gastric cancers. And I think literature also is also concordant with that. So I would think that it is around 10%, not more than that.
right. Dr. Rukmini?
Yes, we also have not never got 40 to 50% positive cases. It's like
Hmm,
not even 10%. We've got around, I think, 5% positive cases.
right. Dr. Arpita? Okay. Dr. Saurav?
Yes, I also don't get so high
So
percentage
much
of
of
gastric
positive,
positive.
yes. Yeah.
We around get 7 to 8%, I believe, for the gastric heart positive cases.
Okay. So next slide, please. Dr. Polami? Dr. Polami, are you there? Dr. Polami? Okay, we move on to the next slide. So we have come to the end of a very insightful panel discussion. I think there is some practical aspect to this HER2 testing in gastric cancer, in breast cancer, and we need to like overcome this practical difficulties, especially the pre-analytics, and go ahead. And what will be your concluding or takeaway from this panel discussion, Dr. Soros? Dr. Anand?
Thank you so much, Dr. Subulakshmi, for the interactive session, and thank you, AstraZeneca, for giving us this platform to interact.
Thank you.
Thank you, Dr. Shubhalakshmi, Dr. Anand, Dr. Arpita, Dr. Rukmini, and Dr. Polami. It was a very insightful discussion, and I think all the audience who are listening will definitely get some better idea regarding the gastric artery expression and its interpretation. Thank you.
Thank you. It was a very enlightening session, and I've also learned a few points again. It has added to my knowledge and the esteemed panel. And I thanks organizers for conducting such webinars regularly.
Thank you, everyone. I learned a lot today, and I feel even a surgical oncologist should be part of such a panel because, I mean, HER2 fixation and everything. I think and surgical
From
oncologists
them,
should be also knowing. Yeah, so we are missing them. We should
from
also be included.
radiologists as well.
Yeah.
Thank you.
Yes. Thank you, Dr. Sengupta, and all our panelists for such a stimulating and highly informative discussion. We now moving ahead. It is my pleasure to introduce Dr. Sudip Das, head and consultant in medical oncology, Manipal Hospital. Dr. Sudip Das is a highly experienced medical and hemato-oncologist in Kolkata, who is who specializes in the diagnosis and treatment of various solid tumors and blood cancers. He will be speaking on the role of HER2 in the gastric gastroesophageal junction carcinoma landscape. Please join me in welcoming Dr. Sudip Das. Sir, over to you, please.
Yeah, thank you for this kind introduction. At the outset, I want to thanks the organizing team and AstraZeneca for giving me this opportunity. And I also beg apology to the entire team for because I am traveling, so my voice may not be so clear. on my behalf, can you share the slide, please?
Yes, sir. Sure, sir. Sure. Sir, it is visible to you?
Yes.
Sir, can you please unmute? Dr. Sudip Das?
Yeah, sorry for the interruption. So I will be speaking on the role of R2 in the gastric G junction tumor, and it will be a clinician's perspective. So there's a comprehensive discussion on the diagnostic part of HER2 in gastric and G junction tumor, but my talk will be centered around the clinical perspective. Next slide, please. Yeah, so this is the brief outline of my presentation. First, some brief outline of epidemiology, that how common is gastric cancer worldwide and in India. Then, what are the diagnostic workup and staging workup? What is the current standard of care? And what is the unmet need for second line HER2 positive gastric cancer? And the management options. Next slide, please. Yeah, first epidemiology. Next. So, gastric cancer is the fifth most common cancer worldwide. And there are close to 9 million new cases in every 2022, and an estimated almost 6 million deaths. So the distribution of gastric cancer is not even. There is an uneven distribution, and Asia, Eastern Europe, particularly Japan, we know, and Western and South America. These are the regions in world where we notice highest uh, evidence and prevalence of gastric cancer. The 5-year relative survival rate of gastric cancer is very disappointing. It is close to 25%. And 6.8% when diagnosed in advanced stage with distant metastasis. The median age of diagnosis worldwide is 68 years. However, in India, often the gastric cancer is being diagnosed in early age, and in India, the median age of diagnosis is 57 years. Next. Next slide, please. Yes. So just like worldwide, gastric cancer is the fifth most common cancer diagnosed among men in India. So this is a common cancer, and the most of the patients are being diagnosed in advanced stage. And even if the patient is getting diagnosed in early stage, the 5-year survival rate is not very great, and it is always less than 50%. And if the patient is being diagnosed in stage 4, then the chance of 5-year survival is close to 5%. Next slide. So, what is the rate of HER2 positivity in India? So, we were listening, I was listening to the previous panel. Dr. Shubhalakshmi rightly pointed out that there are some centers who have reported very high HER2 positivity rate of as high as 40%. But let's go through some large data published in from India. It is a molecular testing in stage 4 stomach cancer in India, a single center experience. Total 114 patients of histologically proven gastric cancer, G junction adenocarcinomas were considered in the study, and 17 patients were HER2 new positive. So the rate of HER2 positivity was 14.9%. There is another data from India where they reported 139 patients were diagnosed with stage 4 G junction or gastric adenocarcinoma. HER2 testing was done in 99 stage 4 patients with a positivity rate of 16%. Next slide, please. So, what about diagnosis and testing? Next slide. Yes. So you know that the diagnosis of gastric cancer or G junction cancer starts with a routine endoscopy and biopsy. So the endoscopy and biopsy is the most sensitive and specific test to detect gastric cancer. If multiple biopsy specimens are taken from a suspicious lesion, then the rate of the sensitivity rate is as high as 98%. Now, once the biopsy confirms the histopathological diagnosis, then comes the question of staging workup. It can be done by a CT scan of thorax, abdomen, and pelvis, or it can be done by FDG PET CT scan. Very often we do MRI abdomen, and these days laparoscopy plus laparoscopy to rule out any peritoneal metastasis has become standard practice for stage evaluation. Next slide. What is the role of biomarker testing? The biomarker testing can improve diagnosis and prognosis in patients in gastric.
Dr. Sudip, can you please unmute yourself?
Yes. So next slide. Yes. So an accumulation of genetic aberration occurs during gastric carcinogenesis, including overexpression of growth factors and receptors, alterations in DNA damage response, and loss of genomic stability. So, what are the key molecular markers which should be tested in advanced gastric cancer? These are HER2 new, PDL1 score, MSI, and Claudin 18.2. And these can be tested by simple IHC. So these should be these are the molecular markers. This is a panel of molecular markers which should be tested in any advanced gastric cancer or G junction tumor. Next slide. Even NCCN guidelines also recommended molecular testing for MSI status, which can be done by either PCR or NGS, or more conveniently by just MMR testing by IHC, because there is a very large concordance between MMR testing by IHC and PCR and NGS test. HER2 testing is compulsory, and PDL1 expression also should be the part of molecular testing, because there is there is proven role of different checkpoint inhibitors in G junction and gastric cancer, and the role of immune checkpoint inhibitor actually becomes pertinent depending on the PDL1 score. So there are different eligibility criteria for different immune checkpoint inhibitor according to the PDL1 score. Next slide. So HER2, we are listening to this session that HER2 is an important biomarker, and this is actually a key driver of tumorigenesis. So in patients with gastric and G junction adenocarcinoma, gastric cancer cases, 12 to 20% are amplified or overexpressed. G junction tumor, the more the proximal, the more is the type, more is the incidence of HER2 positivity. So G junction cancer, the rate is as high as 32%. In intestinal type, the rate is 30%, whereas in diffuse type, the rate is very negligible. It is as low as 5%. Next slide. So HER2 positive gastric or G junction adenocarcinoma is characterized by amplification of the HER2 gene, resulting in overexpression of HER2 receptor. And the intratumoral heterogeneity of HER2 expression is very common in gastric and G junction adenocarcinoma. The intratumoral heterogeneity can be as high as 50% cases. And this is the heterogeneous HER2 expression have worse outcomes than homogeneously HER2 positive gastric cancer. This is associated with a amplification or co-overexpression of other tyrosine kinase receptors such as EGFR or MET and FGFR2, resulting in resistance to trastuzumab therapy, because there are other growth signal pathway which are also activated. Next slide. So NCCN guideline recommended HER2 status is the first assessed by IHC, followed by FISH in equivocal cases. So test for HER2 protein by high expression by IHC. If it is equivocal or 2+, then it should be verified by FISH. Next slide. And this is broadly discussed in the previous panel discussion, that how the technique of HER2 testing in gastric cancer and breast cancer, they are different. So next slide. Yes, so these are the key differences. These are the points which are broadly discussed. In detail, they were discussed. Next slide. So from clinical perspective, what is the current standard of care and unmet need? Next slide. So the patient who is very presenting in very early stage, the patient can be even managed with endoscopic resection or surgery alone. Most of the patient who are in resectable stage 2 or stage 3 or potentially stage 4A, they are actually treated with perioperative chemotherapy and surgery. So it all starts with neoadjuvant chemotherapy followed by surgery and then adjuvant chemotherapy. So because there was a huge success reported in FLOT trial. Then for metastatic gastric cancer, the intent of treatment is palliative, and most of the patients are treated with in first line systemic therapy, mostly in doublet chemotherapy. And the doublet chemotherapy is typically 5-FU or 5-FU metabolites, like either 5-FU or capecitabine plus a platin, mostly either cisplatin or oxaliplatin. These doublets are used mostly. In second line, the options are one chemotherapy, either paclitaxel or irinotecan, and one anti-VEGF inhibitor like ramucirumab. And recently, though in this slide, the in third line only, the IOs are mentioned that the role of immune checkpoint inhibitor in third line, but in present era, there is evidence of immune checkpoint inhibitor even in the first line setting. So they have come up. They are being used in the first line setting. Next slide. So this is the landmark TOGA trial, which actually has proven the role of anti-HER2 therapy in HER2 positive stomach cancer. HER2 positive gastric or G junction tumor patients who were chemotherapy naive. They were randomized into 1:1. The standard chemotherapy was capecitabine or cisplatin or 5-FU or cisplatin, as I was mentioning before, or the chemotherapy plus trastuzumab. The typical dose of trastuzumab 8 mg per kg in the first cycle loading dose, followed by 6 mg per kg every 3 weekly. The primary endpoint of this trial was overall survival, and there are multiple secondary endpoints. Next slide. So this is the endpoints results of TOGA trial. There's a clear-cut overall survival benefit. The hazard ratio for overall survival is 0.74. As you can figure out that in patient with strong HER2 positive tumors, median overall survival was improved from 11.8 months to 16 months. And in the overall population, the overall survival was 11.1 months in chemotherapy only arm versus 13.8 months in chemo plus trastuzumab. What about PFS? Yes, there is a PFS benefit too. The hazard ratio for PFS was 0.71, and the absolute PFS, median PFS was 6.7 months in trastuzumab arm versus 5.5 months in chemotherapy arm. Duration of response was 6.9 months in trastuzumab arm versus 4.8 months in chemotherapy arm. Next slide. This is keynote 811. I just few minutes back in my previous slide, I was mentioning that there is role of IO even in first line setting. So this keynote 811 was about that. Patients with HER2 positive metastatic gastric or G junction tumor, they were treated with the standard of care, that is capox or cisplatin 5-FU chemotherapy plus trastuzumab, or trastuzumab plus chemotherapy doublet plus pembrolizumab, and the dual primary endpoints were PFS and OS. Next slide. These are tumor size reduction. Confirmed overall objective response rate was 74% in the pembrolizumab group versus 51% in the placebo group. 11% patient in pembrolizumab group had CR versus only 3% in chemo plus trastuzumab. Disease control rate was also higher, 96% in IO group. Median duration of response was longer in IO group, 10.6 months versus 9.5 months. The adverse events, grade 3 onwards adverse events were 57% in pembrolizumab group and the similar frequency of grade 3 onwards adverse events in placebo group. Next slide. So pembrolizumab significantly improved progression-free survival and overall survival when combined with first-line trastuzumab and chemotherapy at third interim analysis also. Look at the overall survival, the hazard ratio 0.84, 20 months versus 16.8 months. Look at PFS hazard ratio 0.73, 10 months versus 8.1 months. Next slide. The first line anti-HER2 treatment that did not provide significant improvement in HER2 positive advanced metastatic gastric adenocarcinoma. There is some study like Jacob and Trio 013 logic trial. So these were the trials where the gain in overall survival did not achieve statistical significance. These both the trials were negative trial. Next slide. So trastuzumab plus chemotherapy is the standard first-line treatment for HER2 positive advanced gastric or GE junction adenocarcinoma. It is already established. And after the keynote trial, trastuzumab chemotherapy plus pembrolizumab is also one of the viable option in first-line setting. In second-line setting, the treatment should be paclitaxel or antoken plus ramucirumab. And next slide. So why the patient is progressing after first line? What are the different mechanism? One of the mechanism is down regulation of HER2 expression because they are exposed to HER2 directed therapy. So there is a down regulation of HER2 expression, and that is the major mechanism of acquired resistance to HER2 directed therapy. And however, HER2 is still a valid target in patients who have progressed on trastuzumab, in part due to recovery of anti-EGFR antibody sensitivity. So poor survival outcomes and lack of treatment options drive a need for new HER2 targeted therapy for patients who have progressed on trastuzumab. And that is the reason Enhertu or trastuzumab deruxtecan has a tremendous role to play because of its large payload. That is the reason even it works in a low HER2 new condition. So even though there is a down regulation of HER2 expression, this trastuzumab deruxtecan molecule has a lot of potential. Next slide. So this slide actually shows that the only 75% of patients who were diagnosed as gastric cancer, they received at least first one line of therapy. After progression from first line of therapy, only less than 50% patients they are eligible for second line, and how many patients they received the third line? Only 14% patients. So the median overall survival seen with second line available option is less than 10 months, which is very discouraging. Next slide. Yeah. So this is a trial. It's a regard an international randomized double-blind placebo-controlled phase 3 trial of ramucirumab monotherapy for previously treated advanced or metastatic GE junction tumor. Next slide. And this showed a median overall survival of 5.2 months for ramucirumab versus 3.8 months for placebo. There is a PFS benefit also. Next slide. This is the landmark rainbow trial, which was ramucirumab plus paclitaxel versus only paclitaxel in second line setting. Next slide. Coming to the result of rainbow trial. Yes, the rainbow trial showed that paclitaxel plus ramucirumab is showing overall OS benefit as well as PFS benefit. Next slide. This is keynote 061. Patients of an open phase 3 trial of pembrolizumab versus paclitaxel for participants with advanced or metastatic G-junction tumor who progressed after first-line therapy with a platinum and fluoropyrimidine 5-FU. So, next slide. So, though there was a OS benefit, but it was non-significant. However, the adverse reactions were less in pembrolizumab arm. However, because the OS benefit was not statistically significant, and in the whole cohort, and the patient who had a PDL1 CPS score of more than 10, in those patients, there's a meaningful benefit in overall survival, 10.4 months versus 8 months in favor of paclitaxel. Next slide. These are the three trials which were actually a negative trial. The role of trastuzumab in second line setting, the role of TDM1 and lapatinib in second line setting, and they were all negative trials. Next slide. So the current standard of care in HER2 positive patients, gastric or G-junction tumor, first line preferred is platinum agent doublet plus trastuzumab plus minus pembrolizumab. In second line setting, either paclitaxel ramucirumab or trastuzumab deruxtecan. And second line non-HER2 targeted, pacliramucirumab, irinotecan, paclitaxel, docetaxel. Third line setting, irinotecan, taxane single agent or pembrolizumab. Next slide. So next slide. So we all know the mechanism of action of trastuzumab deruxtecan. It is an antibody drug conjugate. There's a trastuzumab which is linked to with a linker. It is linked to the payload. The payload is actually a topoisomerase 1 inhibitor, and it has a high payload ratio. The ratio is 8:1. So this is more potent than the another ADC, that is TDM1. So next slide. So once the molecule binds to HER2, then there is internalization and the linker is cleavaged. There will be release of topoisomerase 1 inhibitor, and this topoisomerase 1 inhibitor not only enters the tumor cell nucleus and kills those cells. In fact, they can also permeate throughout the cell membrane and enter the nearby tumor cells, causing a bystander cell killing effect. Next slide. So these are the advantage of TDXD. Coming to Destiny Gastric 01 and 02 trial. Next. Yes, this is Destiny Gastric 01, where the patients who are HER2 positive and patients progressed on after at least 2 prior regimens. They are randomized into physician's choice versus TDXD, and the physician's choice options were irinotecan or paclitaxel. Next slide. Look at the objective. Sorry, next slide. Look at the objective response rate. It is 4 times 40% in TDXD versus 11% in physician's choice. There is a 7.9% CR, complete response rate, compared to no complete CR in physician's choice. Next slide. Statistically significant and clinically meaningful PFS and OFS benefit. The hazard ratio for overall survival was 0.59. The magnitude of benefit was more than 4 months. And look at the PFS was also in favor of TDXD. Next slide. Next slide. No new safety profile, and most of the TDXD related adverse events were easily manageable. There is no concern of ILD.
The most of the ILDs were grade 1 only or grade 2. Grade 3 ILD were very few. Next slide. This is Destiny Gastric 02, where the patients were HER2 positive. After progression on first-line trastuzumab containing regimen, they were treated with TDXD. Next slide. Next. So the objective response rate was when the data cutoff was on November 8th, 2021. The objective response rate was as high as 41.8%. There was 5.1% CR, and the median duration of response was also impressive, 8.1 months. Median time to tumor response was also very fast, 1.4 months. Next. Median OS was 12.1 months and median PFS 5.6 months. Next. No new safety concern in Destiny Gastric 02. Next. So NCCN guidelines, also they have clearly mentioned that TDXD is one of the standard second-line HER2 targeted therapy regimen in second-line setting. Next. So to conclude, gastric cancer is the fifth most frequently diagnosed cancer and the fifth leading cause of cancer-related deaths worldwide. HER2 is amplified or overexpressed in 12 to 20% of gastric cancer. In HER2 has survival of overall survival benefit of 12.1 months, unlike any other anti-HER2 agents. Confirmed objective response rate of 41% establishes benefit of Enhertu in patients with HER2 positive gastric cancer in second line setting. And Enhertu is currently DGCI approved for use in patients with locally advanced or metastatic HER2 positive gastric cancer who have received trastuzumab based therapy in first line setting. Next slide. So with this, I want to thank you for your patient listening.
Yes. Thank you, Dr. Sudeep, for the clinically enriching presentation. We now conclude. With that, we come to the close of today's IAIO Expert Insight session. On behalf of IAIO, I extend our heartfelt gratitude to all our sponsors, faculties, and participants for making this session a great success. We hope this discussion today will inspire further research, collaboration, and excellence in gastrointestinal oncology practice. Thank you for joining us. Wishing you all a pleasant evening ahead. Thank you.